Hello, my name is Sun Tran, speaking to you through the medium of skull, and this is my little guide to correcting lateral knee positioning, oddly called the Bum&Cherry technique. By the end of this video, you should be able to identify if a lateral knee x-ray is too externally or internally rotated, and how to correct positioning within 3 seconds of looking at the x-ray. So first we need to know about the anatomy that informs our technique. This is the right knee and what you would see in an AP projection. And we see that visually, the medial condyle is very, very similar to the lateral condyle. And this is the same case as we turn to the lateral perspective. However, one distinct difference is the presence of this little bony prominence here called the adductor tubercle, and that sits just superiorly to the medial condyle, which is absent on the lateral side. So if we follow the posterior line of the lateral condyle, we see that it's smooth and uninterrupted, whereas the posterior line of the medial condyle gets interrupted by the adductor tubercle. So the main takeaway to this is if we see the prominence of the adductor tubercle on a femoral condyle, we know that it's the medial one. And this is what it looks like on an x-ray. A very clear bony prominence, and we can use it to find the medial condyle. On this x-ray, we see that the adductor tubercle is here, just superior to this femoral condyle. And since we know that the adductor tubercle sits superiorly to the medial condyle, we can conclude that this condyle, which has been projected more anteriorly, is the medial one. Therefore, this condyle is the lateral one, and we can make sure by following its posterior line. It's smooth and uninterrupted due to the absence of an adductor tubercle. We can use the same process for this next x-ray. Here we can see that the adductor tubercle is superior to the femoral condyle that is projected more posteriorly. So again, since we know that the adductor tubercle is on the medial condyle, we know that this condyle is the medial one, and this condyle that is projected more anterior is the lateral condyle, confirmed by its smooth lines. One of these x-rays is too externally rotated, and the other is too internally rotated. But which is which? I'll give you 3 seconds to figure out which one. Did you get it in time? Well, you will by the end of this video. This is the one that is too externally rotated. But how do we know? My apologies if you're having your dinner, but this is my leg. So let's see what happens to our condyles when we overly externally rotate our leg, and you can follow along at home too. Place the fingers of one hand on your medial condyle and the fingers of the other hand on the lateral condyle, and follow along with our lovely leg model. In fact, I'm not carrying on until you do. Done? Good. When we externally rotate our leg too much, our medial condyle, denoted in red here, moves more anteriorly. And if you're following along, you'll find that your fingers on the medial condyle also move more anteriorly. Our lateral condyle, denoted here in teal, moves more posteriorly. You'll find that your fingers on your lateral condyle also move more posteriorly. So we can expect the medial condyle to be projected more anterior on the x-ray, and the lateral condyle to be projected more posterior, which is what has happened on our x-ray here. The medial condyle has moved more anterior, and we can confirm this with our little adductor tubercle. It's superior to the condyle, which has been projected more anterior, so we know that this x-ray is too externally rotated. So that must mean that this x-ray is too internally rotated, and we can use the same system to work this out. When our lovely leg model internally rotates the knee, the medial condyle moves more posteriorly, and the lateral condyle moves more anteriorly, which is what you'll find if you place your fingers on your own condyles and internally rotate your knee. So on the x-ray, we can expect the medial condyle to be projected more posterior and the lateral condyle to be projected more anterior, which is what has happened on this x-ray. And we can confirm this using our trusty adductor tubercle. It appears superior to the condyle that is projected more posterior, which we have just confirmed happens when we internally rotate the leg. But we can't really go through that entire process and start touching our knees every time we do a lateral knee x-ray. Well, we can, but the patient would have moved by then, and we're back to square one. So time is of the essence, especially if they're weight-bearing. Also, sometimes due to rotation, we can't quite see our new favourite bony prominence, the adductor tubercle, and using the fibular head as a guide can sometimes be unreliable. This is where our Bum&Cherry technique comes in. Here are a number of x-rays, 3 that are too internally rotated, and 3 that are too externally rotated. Have a look at them and you'll start to notice a key visual difference between them. If we look at the posterior lines of the condyles that extend superiorly, you'll see that in each of the x-rays that are too internally rotated, these lines converge and meet further proximal on the femur, shown here, here, and here. Whereas in the x-rays that are too externally rotated, the posterior lines of the condyles don't converge or meet as we move more proximal along the femur, shown here, here, and here. And it's this visual difference that forms the magic behind the Bum&Cherry technique. If we have a closer look at the X-rays that are too internally rotated, the posterior lines converge as we follow the posterior lines of the condyles superiorly, and this forms the stalk of a cherry. So whenever you see these posterior lines meeting or converging, we know that this is a cherry. Cherries are too internally rotated, as we've confirmed using the adductor tubercle and our gorgeous leg model. Cherries need external rotation or turning out to correct positioning and superimpose the condyles, and we remember this by saying the phrase out of the cherry. It works again with this X-ray here. The posterior lines of the condyles converge as we move more superiorly, forming the stalk of a cherry. So we know that this X-ray is a cherry. We've learnt now that cherries are too internally rotated, and remember the phrase out of the cherry to know to externally rotate or turn the knee out to correct positioning and superimpose the condyles. Again, on this X-ray, the posterior lines eventually meet here, so it's a cherry. Cherries are too internally rotated. We remember the phrase out of the cherry, so we'll turn this knee out or externally rotate it to fix positioning. So onto the externally rotated knees. On the cherries that were too internally rotated, the posterior lines met or converged, but here they don't meet or converge at all, and in my weird eye at least, they form the shape of a bum. We know by the position of the adductor tubercle and our questionable leg model that bums are too externally rotated and therefore need internal rotation or turning in to correct positioning and superimpose the condyles. We remember this with the phrase into the bum. Let's apply it to this X-ray. Again, the posterior lines don't meet or converge, so we know that this is a bum, and therefore we know that it needs internal rotation or turning in to correct positioning and superimpose the condyles by remembering the phrase into the bum. Quickly for this one, the posterior lines don't meet, so we know that this is a bum. We remember the phrase into the bum, so we'll internally rotate the knee or turn the knee in to correct positioning and superimpose the condyles. So with the Bum&Cherry, we can quickly spot if a lateral knee is too externally or internally rotated, and which way to rotate the knee to correct positioning by identifying just one feature. So let's do some more examples. So here we have a horizontal beam lateral, so let's turn it so we can see our technique more easily. Here the posterior lines don't meet, so we know it's a bum. We've learned that bums are too externally rotated, and remember the phrase into the bum to know that it needs turning in or internal rotation to superimpose the condyles. With this example, the posterior lines eventually meet up here, so this is a cherry as they form the stalk. We've learned that cherries are too internally rotated, and remember the phrase out of the cherry, which tells us to turn the knee out or use external rotation to superimpose the condyles. Let's speed things up with this example. Posterior lines don't meet, which means it's a bum. Into the bum, turn the knee in to superimpose the condyles. And with this one, posterior lines meet, which makes it a cherry. Out of the cherry, turn the knee out to superimpose the condyles. So hopefully you can see how this Bum&Cherry technique can help you make quicker and more confident decisions about correcting your lateral knee positioning, reducing unnecessary exposure, and reducing time spent in the examination room by the patient, leading to a better quality of care and practice. All you need to remember is into the bum and out of the cherry. And if you're having particular trouble, you can use other anatomical landmarks such as the lateral sulcus, which only appears on the lateral condyle, and the fibula head to inform your decision. But that's all for this lesson. I've put my Twitter on the screen, so if you have any questions or queries or abuse, please let me know. Until next time, happy X-raying, and remember, into the bum and out of the cherry.